Well, one of the unique opportunities that members of ICOS have is to apply for certification as a center of excellence. And one of the requirements for certification is that each program identify quality improvement projects that they've developed at their institution. And these are programs that contribute in some way to the increased efficiency in operations or especially improvement in patient care. And we've been so impressed by the quality of these programs that we wanted to share them with our community. So one way that we're doing that is by way of a series of short recordings highlighting some of our gold standard programs. So today it's a pleasure to welcome Dr. Gagan Sahni, Director of Cardio-Oncology and Inpatient Cardiology Consult Services at Mount Sinai Hospital in New York City. She's also a Fellow of ICOS. So Dr. Sahni, thanks for being with us and for sharing one of your quality improvement projects with our community.
Thank you, Steve. Thank you for this opportunity, and very proud to share our carcinoid heart disease QA/QI project at Mount Sinai Cardiovascular Institute, now known as Mount Sinai Hospital of New York. The reason why we had picked this project a few years ago was because we are a very high volume center for referrals for carcinoid heart disease, and our total cumulative count that comes over for carcinoid evaluation from our oncologist crosses 1,000 in a given year. So going ahead to our epidemiology of carcinoid heart disease, and I'm going to skip to my second slide, is I want to go down the epidemiology of carcinoid heart disease a bit and see how many of our patients actually get diagnosed with neuroendocrine tumors and subsequently develop carcinoid heart disease. So if we were to take the general population, the incidence of neuroendocrine tumors is actually not that big. It amounts to about the prevalence is about 2.5 to 5 cases per 100,000 in the general population. But out of these neuroendocrine tumors, a lot of them are non-secretory, and only about 30 to 40% of all neuroendocrine tumors historically present with the classical carcinoid syndrome, which is usually a constellation of symptoms including flushing, diarrhea, abdominal pain, wheezing, etc., all a constellation resulting from the release of vasoactive substances such as serotonin and, in rare cases, chromogranin as well. What is interesting is that the patients who develop carcinoid syndrome, there is about a 20 to 50% chance that these patients with elevated levels of vasoactive substances such as serotonin, chromogranin, presenting with carcinoid syndrome, especially if they have liver metastases, then go on in subsequent years to develop carcinoid heart disease. So this is the general epidemiology of how prevalent not only neuroendocrine tumors are, but what percentage of these, which would be about 50% of those presenting with carcinoid syndrome, then go on to developing carcinoid heart disease. The carcinoid heart disease, just to characterize it for people who don't see a lot of these, is a degeneration of mostly the right-sided heart valves, just tricuspid and pulmonic, as a sequelae of the carcinoid syndrome. So serotonin, chromogranin secreted by the neuroendocrine tumors, especially if it's that of midgut with liver metastases. And why with liver metastases is because the liver is a place where the serotonin gets deactivated. And so if there is a huge bulk of disease sitting in the liver, a lot of the serotonin does not get inactivated and is able to, through the IVC, then reach the right-sided valves, and in a minority of cases, even to the left-sided valves through interatrial connections or interventricular connections, able to reach through an ASD, PFO, or a PDA, able to reach the left-sided valves as well. And then it leads to the deposition of plaques in the endocardial surfaces of the heart valves, including the subvalvular apparatus and cardiac chambers in some cases, leading to valvular heart disease and right-sided heart failure. So historically, studies have reported that about 20 to 70% of patients who are presenting with carcinoid syndrome and about 60% of those who have metastatic disease to the liver will develop carcinoid heart disease. But really, this is all historical data because it has been inconsistently reported due to lack of complete screening or follow-up, not taking into account biomarkers. And remember, most of these studies were before the advent and establishment of dedicated cardio-oncology clinics, where we were looking diligently and monitoring these patients with an algorithm for surveillance. Having said that, this is the carcinoid heart disease surveillance algorithm that we devised at the Mount Sinai Hospital for neuroendocrine tumors. And so it's a busy slide, but I'm going to take you slowly down it. So most patients that get referred to us from oncology and from our NET Center of Excellence is those presenting with carcinoid syndrome and or liver metastases, because as I explained, these are the patients that have a higher bulk of serotonin and 5-HIAA levels, which then go on to deposit on the right-sided valves and produce carcinoid heart disease. So these patients from the oncology teams then get referred to cardio-oncology mostly, though some of them have their private cardiologists either within or outside the center. And these patients, even on the day that they get referred to us, also get coordinated to get a baseline transthoracic echo with a bubble study at least once. And a bubble study is kind of essential so that we establish whether this interatrial, interventricular shunt is present, so that we know whether we are looking out for just the right-sided valves for carcinoid heart disease, or are we looking at the left-sided valves as well in future surveillance. And we also have baseline serum serotonin or 5-HIAA levels and cardiac biomarkers, which is mostly pro-BNP, which has now become standard of care at our institution, though in the past years we've been using BNP as well. Having said that, I will come later to how we expedite this, but the serum serotonin levels and the 5-HIA levels in pro-BNP are sent by the oncology team already. So this data is available to us in cardio-oncology on the day we see the patient for the first patient visit. So having had this information ready to us during our first cardio-oncology visit, we look for the classical signs of carcinoid heart disease on the TTE, which has been described very well in echo studies, such as in Bhattacharya et al., as well as in the ASC guidelines. And so if the TTE is showing possible signs of carcinoid heart disease or serum serotonin levels, and this is not total, but serum serotonin levels of greater than 500 nanograms per ml, or any of the cardiac biomarkers, including pro-BNP is greater than 260, or a BNP level of greater than 100 if the pro-BNP was not available, or they already come to us as established carcinoid heart disease from prior history, whether they are or not they've been prior diagnosed, or they've had some kind of valve surgery, or valve-in-valve surgery, or prosthetic heart valve dysfunction from prior history, then we see them, we expedite their visit, and we do a regular surveillance for monitoring the known carcinoid heart disease with a transthoracic echo and cardiac biomarkers at least every 6 months, and even every 3 months, depending on the severity of the disease. So the classic signs that we look for in echocardiographic signs of carcinoid heart disease are, of course, the thickening of the valve leaflets, the subvalvular apparatus, the decreased excursion of the leaflets, shortened chordae, retraction of the valve, and of course, the amount of regurgitation or stenosis that these valves go through, which can range anywhere from mild to severe. Similarly, extrapolating these findings onto the pulmonic valve and even the aortic and mitral if there happens to be an interatrial or interventricular shunt between the right and left side. Of course, there would be signs of right-sided heart failure, which would be dilated right atrium, dilated IVC, right ventricle being dilated with RV dysfunction, or we might get clues from elevated biomarkers, elevated troponin if they were available, though it's not part of the algorithm, or a PET scan or a gallium dotatate available from the oncological workup where it is lighting up in the myocardium, then we also look for signs of cardiac metastases in these patients, going beyond the valvular involvement of these patients. If the patients do not have a transthoracic echo showing any of these signs of carcinoid heart disease, and their serotonin as well as cardiac biomarkers are below the cutoffs, then these patients were monitored regularly on at least an annual basis with biomarkers as well as an annual transthoracic echo. Having said that, if any of the times during the oncological workup, if the serotonin levels started rising, even if they were normal at the beginning of the year, or the proBNP levels started increasing before below their baseline to a value of greater than 260, then these patients would then cross over to the left-hand side, and we would start monitoring them and seeing them in the clinic earlier. What will we do if we did detect carcinoid heart disease? These patients were seen on a 3 to 6 monthly basis in our clinic. And the referral algorithm for us would not just be seen by Cardio-Oncology, but also a multidisciplinary platform to refer them to the appropriate interventional teams as well. So we would properly start them on diuretics if a right valvular heart failure and RV dysfunction and right heart failure was present. If the transthoracic echo did not give us adequate information, if we needed to assess if the tricuspid regurgitation was from carcinoid versus other etiologies or the severity of it, we would obtain additional imaging such as cardiac MRI or even TEE in some cases. We've had cases where people had portal hypertension, had severe TR and right-sided heart failure from non-carcinoid reasons, having a concomitant neuroendocrine tumor. So also to keep in mind red herrings. So if we do need additional imaging beyond transthoracic echo to establish whether the moderate to severe tricuspid regurgitation or pulmonic regurgitation was entirely due to a neuroendocrine tumor, we would obtain that additional imaging. Of course, we would work closely with our oncology colleagues to control the serotonin and 5-HIA levels immediately with telorostat, with a lanreotide and short-acting octreotide, all our somatostatin analogs, refer them to nuclear medicine to initiate the PRRT therapy, which is the peptide-related therapy, as radionuclide therapy, as well as chemotherapy, including evaluation and enrollment in trials such as the CAPITUM, which involves capecitabine and temozolomide, and of course, mTOR inhibitors such as everolimus. So whatever the plan would be, we would get involved with our oncology colleagues to rapidly reduce not just the levels, but to prevent further progression of the disease, whether they were pre-intervention or post-intervention for the valve disease. Of course, oncosurgical intervention and tumor board occurs at the Mount Sinai on every Thursday, where we will also discuss interventions such as debulking surgery and hepatic embolization by interventional radiology. And if they did get to the point of severe valvular disease, which was attributed entirely to the neuroendocrine tumor, we would refer them early to cardiothoracic surgery for early surgical valve intervention. And if this was a prosthetic valve dysfunction that was occurring because of progressive NET, then we would refer them early to interventional cardiology for percutaneous valve-in-valve intervention. So the way the timeline of this pathway, this algorithm occurred was that in 2014, we established our cardio-oncology clinic at the Mount Sinai Cardiovascular Institute. And initially, before we were implementing this algorithm, there were barely 5 referrals that, I'd had for a neuroendocrine tumor, out of which 3 patients already came with an established carcinoid heart disease. But when we implemented this protocol for early referral screening, as well as a multidisciplinary tumor board and discussion for cytoreductive and reduction of 5-year and early referral to cardiology interventions, we garnered about 121 referrals to cardio-oncology for neuroendocrine tumors, out of which 25%, about 30 patients, manifested themselves to be having carcinoid heart disease. And even as I'm presenting this is old data, because as of now, there've been an additional 30 referrals that have not included in this presentation for the sake of showing you the burden of disease and epidemiology at just our one single center experience. The way the access to care for these neuroendocrine tumors was that we started off with education of our cardiology attendings, oncology, as well as cardiology nurse practitioners and physician providers, even if they were in the general community, for timely referrals. And there was one access number, which would be my email pretty much, and my office number for scheduling. And then I would have sort of a tree-like referral system for scheduling. And we would prefer an email versus just picking up the phone, just because I knew that I would answer that email and transfer it to the staff that was responsible for scheduling and arranging for labs as well as imaging, etc. And we could track it. We would have a paper trail, or rather a internet trail of when these patients were referred and how quickly they got to us. And cardiac biomarkers were already done with the labs that were being done in the routine oncology labs with our oncology colleagues, to avoid additional reasons of accessing these patients or subjecting them to venipunctures and multiple appointments, and so that the data would be available to us during our first index visit for each of these patients. And do keep in mind, these are carcinoid patients with frequent crises, and have had patients that would pretty much go into crisis if they had multiple venipunctures itself as well. So keeping that in mind as well. And of course, if I already had their transthoracic echoes or imaging from outside, as well as these biomarkers available, I would also expedite the CT surgeon or the interventional cardiologist to see them the same day as they were coming to us, because a lot of these referrals were tertiary referrals coming to us from the community in the tri-state area. And if any of these patients needed telemedicine visits, I've the cardio-oncologists, especially me, have telemedicine licenses in several surrounding states, and we would expedite follow-up, especially to discuss additional test results, monitoring diuretics, etc. I would follow them up with telemedicine appointments as well. Having said that, this is our data of our QA/QI project, that of the 121 patients that were referred in this 5-year period of NET referrals. And keep in mind, this includes our doc years of COVID years, which is 2020 and 2021, where referrals were actually slowed. And despite that 2-year paucity of data, we actually garnered about 121 referrals that we were continuously monitoring for carcinoid heart disease, with about 75%, 91 of these patients had no echo or biomarker evidence of carcinoid heart disease. And out of the remaining 30 patients that had evidence of carcinoid heart disease, here was the breakup. So about 15% of these, which was about 18 out of the 30 patients, they continued to have regular carcinoid heart disease surveillance with biomarkers and echoes, which could be yearly or 6 monthly or even earlier, depending on how severe the disease was on imaging or their presentation. And the remaining, which were the remaining 12 patients, one of them was just a history of prior valve disease, which was stable, this light lime green. And out of the remaining 12 patients, 11 patients, which is 7 patients, went to CT surgery, and 4 patients, which is this darker lime green, were referred with a history of prior valve surgery to our interventional colleagues for a valve-in-valve for a dehiscence or a prosthetic valve dysfunction arising from their serotonin and their chromogranin attacking their priorly intervened on valve surgery. So we had about 11 out of the 30 going for some intervention, 1 being watched with prior valve intervention, and 18 with no intervention being watched closely with evidence of carcinoid heart disease. And this next slide is just a close-up of the 30 carcinoid heart disease patients that were either being watched, sent to surgery during the 5-year interval between 2018 to 2023, and those that went for valve-in-valve referral. And looking closely, just to give an idea of what these demographics of these baseline patients was, they were pretty well matched in terms of, whether they were having a carcinoid heart disease or not. They were about equally matched, about 1/3 of them were male, a majority of them being female. They had equal prevalence of hypertension, hyperlipidemia, diabetes, coronary artery disease, atrial flutter fibrillation, atrial arrhythmias, chronic kidney disease, history of coronary vascularization. All of these were well matched, and it did not seem to portend any of these known cardiovascular risk factors, did not portend whether they would go on to develop carcinoid heart disease or not. But what would portend whether they would go on to develop carcinoid heart disease or not were three things. And one was that they already presented with heart failure. These patients were obviously, they pre-selected themselves out to most likely have carcinoid heart disease. And the reason for their congestive heart failure was usually valve disease from the underlying neuroendocrine tumor. And of course, clearly the patients who had history of prior valve surgery already had carcinoid heart disease, so they were pre-selected there. And those patients, that we only had about 4 patients out of the 30 which had evidence of myocardial or pericardial cardiac metastases. This, of course, was higher in the group that had carcinoid heart disease. Going on to whether the biomarkers, and I know there are studies which have shown that probably pro-BNP elevation of greater than 260 might portend catching these patients for carcinoid heart disease, even before the transthoracic echo shows classical signs of carcinoid heart disease. But at our institution, using that same level cutoff of pro-BNP, yes, we did see a trend towards, of course, higher serotonin levels in patients that had carcinoid heart disease. They had higher BNP levels and higher pro-BNP, but none of these markers predicted or were associated with the incidence of carcinoid heart disease in the 5-year follow-up. Yes, they had a trend towards higher values, but in our institution, the transthoracic echo stayed as the gold standard of establishing whether they had or did not have carcinoid heart disease. The outcomes in this 5-year for all comers was that our carcinoid heart disease, as anticipated, of course, had a higher mortality than patients with neuroendocrine tumor that did not have carcinoid heart disease. And this is clearly the money slide here, which is a reason for early referral and for establishment of cardio-oncology clinics, where the access to care for all neuroendocrine tumor patients is essential, because even if you have a neuroendocrine tumor, but you don't have carcinoid heart disease, their overall mortality, and of course, these are not Kaplan-Meier curves, this is just our cumulative incidence in a 5-year snapshot view, a longitudinal assessment over a 5-year period, we basically saw that even if you had neuroendocrine tumor, your overall mortality was about 8 to 9%. But if the same neuroendocrine tumor patients had evidence of carcinoid heart disease, the mortality jumped up to 26%. So just for this, the early referral detection and referral of these patients is so important for detecting carcinoid heart disease in our NET patients. And the cardiovascular mortality, of course, was the bulk of the mortality, because 16% was cardiovascular mortality. And if you did not have carcinoid heart disease, yes, their mortality was mostly cancer-related, but almost none of them, even if they have CAD, heart failure from other causes, etc., did not in this longitudinal 5-year follow-up have any cardiovascular mortality. So most of these patients were actually dying of their heart failure. And just to point that out in the asterisk, that even in the cardiovascular mortality, only one of these 11 patients that was referred to CTS and interventional had an operated death. So this cardiovascular mortality included a procedural mortality, one patient out of these 11 that had an intervention for carcinoid heart disease, which amounts to about a 9% procedural mortality. And of course, a bulk of them, about half of them, would present with heart failure if they had carcinoid heart disease, versus the non-CHD. Yes, there was a 4% incidence of non-carcinoid heart failure in those patients. As I said, they could have heart failure from other causes, but most of the patients in the carcinoid heart cohort was a valvular heart failure. So the way we measured whether this carcinoid heart disease project, you look at metrics of any QA/QI project, and these are the 6 mainstays of any QA/QI project, looking at the measures that you employ, if those measures were having any outcomes data that made a difference to even institute these algorithms and QA/QI projects, and whether patients were satisfied with it, how we could ensure compliance, not just in terms of patients and patient satisfaction, but also people on the other side, the staff running it, as well as how sustainable such projects are. So having looked at each of these, we basically saw that all the 121 patients, and of course, an additional 30 that we are seeing within this year, about 100% of these who got referred to a cardio-oncology clinic got at least 6 to 12 monthly biomarkers, and 95% of them got at least an annual echocardiogram. So these were pretty decently followed in terms of both imaging and biomarkers once they got plugged into our system. The average wait time, because of the single down flow or trickle down of these appointments and follow-up, was the average wait time for a cardio-oncology appointment was less than 30 days if we did not know or did not have any biomarker or TT evidence that they had carcinoid heart disease. But if they came to us with pre-existing carcinoid heart disease, or there was imaging from a prior cardiologist or provider or elevated biomarkers, we would see them within 10 days. And if they needed intervention for moderate to severe valvular disease that had already been established according to our algorithm, the time to referral to CT surgery or valve interventions, because remember, we coordinated visits sometimes within the same day, was less than 2 weeks. So we did see that by education, by instituting this algorithm, there was a 30-fold from 5 patients to 121 and counting, a 30 times increase in NET referrals to cardio-oncology and cardiac testing that grew exponentially with the implementation of our pathway. And the prevalence of closely watched NET patients with detection of carcinoid heart disease was similar to other contemporary studies. So as I showed you, it was about 30 out of the 121, which is a 25% prevalence. But interestingly, and remember, this is just an observational retrospective analysis of our QA project, we had a lower cardiovascular mortality in this 5-year on longitudinal follow-up of 16%, which traditionally, even in latest data from Duke and Mayo, has been as high as 30 to 35%. So a 5-year cardiovascular mortality of 16% and a much lower operative mortality also of 9%, likely because of closer surveillance, early referrals, cardiac interventions done in time, and more essentially because we're such a high volume operator working in a multidisciplinary setting. And, the patients clearly, because of the early referral, getting plugged into all their testing within a short duration span with lesser appointments, the likelihood of referral as per Press Ganey was, more than 98 percentile with overall rating of 4.9 out of 5 in our carcinoid patients. And our patient compliance measures, we looked at our basically no-show rate for both testing as well as our clinical visits. And because of the same-day testing, as well as referral system that we had set up and the telemedicine option so that, they would follow up with testing and know their test results and be an optimized diuretics and, be taking their octreotide and their telorostat, et cetera. We had a less than 10% no-show rate. And of course, dot satisfaction, because it was guided through a single email chain where we could follow the flow of the referrals as well as scheduling. It ensured timely testing and scheduling. And of course, this ongoing implementation and referral schemata as part of the algorithm is ongoing. And within this year, we had about 121 patients for 5 years, and we already have 30 to 35 patients within this last 6-month period already that I haven't included in the graphs that I showed you. So just showing you the exponential rise and the ease of referral, as well as providing a standard of care and access to care to these patients. And with this, these are our budding cardio-oncologists. that helped me put up this data, and we're, keeping the algorithm open for our patients. And this is back to my favorite photo of me with the penguins in Antarctica. Thank you, Steve, for this opportunity, and for sharing and letting us share our QA career project in neuroendocrine tumors and carcinoid heart disease.
Wonderful. Thank you so much, Dr. Sahni. Again, we appreciate the outstanding work you're doing, and of course, for taking the time to share it with our community. We really appreciate it.
Thank you, Steve.